morning, everyone. Sorry, I think I should have taken a drink before I said good morning. I just want to point out that if you haven't done so already, please go ahead and let us know where you're joining from today. We're excited to have people who have signed up from all over the US today, and actually some international folks as well. We also would like you to put in there, if you're seeking CEU units today, credits today, please put in your name and your degree both at the beginning of the session, at the end of the session for our attendance purposes. Thank you. And we'll get started in just a quick moment. I want to make sure that we're all set. Okay, we've got a couple people that are still trying to get into the room, so we'll give them another minute before we get going. Well, I want to introduce myself as the person who is welcoming you today. I'm Karen Brown, and I'm currently the Gerontology Programs Manager at Ithaca College. And Lisa Richards is also here with us today. She'll be helping monitor the chat and making sure that we stay on track technology-wise, and she is the Programs Manager for the Finger Lakes Geriatric Education Center at the Gerontology Institute with Ithaca College. And we have both her and the funding through this program to thank for today's workshop, and actually the whole series that we've been able to provide for you this spring on health literacy. The Finger Lakes Geriatric Education Center covers 25 counties in upstate New York. You can see by the map. And we at Ithaca College are a part of the University of Rochester's Geriatric Workforce Enhancement Program, which is funded through the Health and Human Services Geriatric Workforce Enhancement Program. And we're really excited to have you here today to be able to experience some of the experts in health literacy as they share some tips and best practices with us. For those of you who are here to attend for your social work continuing education credits, I want you to know that they are approved through the University of Rochester's Medical Center for Experiential Learning, and that it is recognized by New York State's Education Department for State Board of Social Work as an approved provider of continuing educations for licensed social worker SW005. I have attached in an email that you should have received this morning a PDF of how to actually access your information. And this is important because although Ithaca College is the one that is sponsoring this today, it is through the University of Rochester Center for Experiential Learning that handles the CEUs. So you would need to create your account with them and sign in through there. So there is a step-by-step guide that you received, as well as there's information on who to call if you need help with that. Please allow 3 to 4 weeks for the credits to show in your transcript. It takes a little time for us to get the attendance there and for it to get added in. And before we get started, I just want to make sure that Cindy is back. Oh, she is, okay. I didn't want to introduce you and be like, oh, she's not really here. I'm so excited today to be able to introduce Cindy Brock to you. For me, it's kind of like having the superhero here. when I started working in health literacy and doing presentations, every great article or useful tool or anything that I came across always had Cindy's name associated with it or as an author. So for me, I'm so thrilled to have her today. And Cindy is the Senior Healthcare Researcher at the Agency for Healthcare Research and Quality, also known as AHRQ, which is a part of the U.S. Department of Health and Human Services. Cindy is the co-chair of the HHS Health Literacy Work Groups and serves on the HHS Language Access Steering Committee. As a lead for AHRQ's health literacy activities, Cindy's projects have included the development of the Health Literacy Universal Toolkit, the CAHPS item set for addressing health literacy, the AHRQ Informed Consent and Authorization Toolkit for Minimal Risk Research, making informed consent and informed choice training modules for the healthcare leaders and professionals, and the Patient Education Materials Assessment Tool, the PEMAT. She is also the point person for the Cultural and Linguistic Competence and served on the National Project Advisory Committee to enhance the national standards for culturally and linguistically appropriate services. In addition to overseeing the development of the Team STEPS Limited English Proficiency LEP module, Cindy commissioned and co-authored the Re-Engineered Discharge Toolkit to address the needs of diverse patients. Cindy served on the National Academy of Medicine's Roundtable on Health Literacy, where she led an effort to define the 10 attributes of a health literate organization. Cindy is the founding editorial board member of the journal HLRP, Health Literacy Research and Practice. She is also a frequent speaker at the national conferences and on webinars, and has published book chapters, blogs, and in journals such as Health Affairs, Journal of General Internal Medicine, Journal for Healthcare Quality, and Journal of Healthcare Communication and Medical Care. And with that, I am happy to turn this over to Cindy, and I'm going to stop sharing and let her start her presentation. Oh, one thing I want to add as she's putting up her slides is that Lisa and I will manage the chat for her, but she's also going to allow for questions at certain sections of the presentation. So we'll be having questions throughout and also at the end. Thank you.
Thanks so much for that incredible introduction. And I'm so pleased to be with all of you today. I have seemed to manage to put the chat up while still in presenter mode, but I won't be reading it while talking. I'm not quite that good at multitasking, but please, I really encourage you throughout the presentation to chat to each other, chat questions, and I will be pausing the presentation because we're here for a couple of hours to try and engage you in discussion. So let's get started. Let's see if my slides will advance. There we go. So first, I have a disclosure. It is not of a financial nature, but I am an employee of the Agency for Healthcare Research and Quality. That is part of the U.S. Department of Health and Human Services, which takes no responsibility whatsoever for anything that I say. Everything I say is mine and mine alone. But you will see a bias in this presentation in that I will be presenting a lot of tools and resources from HHS and AHRQ. For those of you who aren't familiar with AHRQ, I'm just going to spend a 1-minute infomercial on who we are, what we do. AHRQ's work falls primarily in 3 buckets. We invest in research to understand how to make healthcare safer and improve quality. We create materials to teach and train healthcare professionals and systems to improve care for their patients. And that's where a lot of the work that you'll see today falls in. And we also generate measures and data to track and improve performance of the U.S. healthcare system. So an overview of what I'm going to try and cover this morning, and apologies for those who are, it is not morning where you're located, but going to talk a little bit about why we should be addressing health literacy at all. And then very importantly, that system change is key. We'll be talking about adopting health literacy universal precautions, and particularly diving down a little bit into improving written and spoken communication in particular. And then I'll spend a little time on language and culture, which is a very important but often overlooked aspect of health literacy. And finally, talking about becoming a health literate organization. And we'll talk more about what that means. So why address health literacy? First, I know this is part of a series on health literacy, and many of you may be well steeped in health literacy, but I did want to start out with a reminder that we are not just talking about reading. The word literacy in health literacy sometimes leads people astray, but health literacy is much broader than that. It's been beyond just written communication, it's spoken communication, it's being able to use numbers and do math, about using health information and navigating the healthcare system. So when I say health literacy, we should be thinking broadly like that. And I also want to take a moment to remind us all of the daunting task that we all face in terms of managing our own health. And this example is of a person with chronic disease, and we all do some version of this. We want people to live healthy lifestyles and make changes in what they eat and their exercise. We want them to be alert about symptoms. We want them to take medication safely according to directions. We want them to be active and seek out care when they need it and do all the things involved. And I'm not even mentioning here the insurance tasks that people need to perform. And then the interactions with healthcare professionals, that they have to be the ones to relate the information about what is going on with them, because they are the experts in themselves. And the fact is we don't do a very good job of helping patients with these tasks. Take, for example, how we're doing with providing information that's clear and accessible. You see before you some data. This is based on a survey that was done of low-income Californians. And first they asked, do you have all the information, health information you need, or would you like more? And you can see it's a fairly even split. 44% said, yep, got all I need, thank you very much. 55% said, well, I'd be interested in some more. But then they changed the question. They said, what if the information were clear and easily accessible? And all of a sudden you see it shoot up to 71% want more information. And what that says to me is, a good 20% of people don't expect information to be clear, that they don't want more information because they anticipate they are not going to understand it, won't be able to use it. And that is a pretty sorry state of affairs. This slide is relating my own personal experience at frustrations with trying to get my mother a COVID-19 vaccination. She lives in New York City. She has doctors with the New York hospital system, and we looked for appointments there, no appointments available. And I say we, I meant me. My mother is now 89 years old. This task was going to be well beyond her abilities. But we were fortunate and got an appointment at Mount Sinai. We're very excited, and then got an email the day before saying, sorry, we've run out of vaccine. So then I went on the state site, which you might be familiar with, and they were said they had appointment availability at the Javits Convention Center. But when I got on there and I looked at each date, no appointment availability. And finally, New York City had its own system for trying to find pharmacies and other locations. And eventually, we were able to get an appointment with an urgent care center. But, look at what it took. My mother says, I don't know what I would do. What do people who don't have a CINDI do? And that's what we need, is we need a healthcare system where you don't need your own CINDI. But unfortunately, what we have is a cycle of crisis care. We have one where it's kind of a non-system, that nobody checks patient understanding or tries to coordinate care. Patients ping pong among providers. They go in and out of the hospital, and the result is poor health outcomes. Now, I don't mean to disparage anybody's system. I'm sure, the present company accepted here, but I think a lot of us are disappointed with our own care, and we are, by virtue of being on this webinar, are relatively privileged, relatively educationally privileged, sophistication in understanding healthcare, and we have problems too. So I'm going to take out my magic wand, and I invite you to join me on an exercise of imagining a different kind of health system. And I'm going to do that by introducing you to my fictional friend here, Maria. And Maria is 73 years old. She's got heart failure, she's got diabetes, and suffers from depression. Her doctor office calls her to make an appointment because the labs that they most recently got back showed that her diabetes wasn't being well controlled. Her blood sugar was too high. And the scheduler reminded her to take all of her medicines, bring them into the office, all of her medicines, all of her supplements, which they do every time she has an appointment. And when she arrives, the receptionist asks whether she'd like some help filling out the forms. And Maria looks them over, and actually they're kind of simple and easy to fill out. So she fills them out herself. The medical assistant takes her back, and together they go over all of her medicines. And Maria is asked to explain what each medicine is for, to demonstrate how she takes them. Next, the doctor comes in, reviews the forms that Maria filled out, and asks her, what does she understand about her diabetes? After discussing that, he talks about what her options are. Changing her diet, exercising, taking medicine, and he carefully explains the benefits and risks of each option and checks that she's understood by asking her to explain back to him what she understood by what he said. Well, there are some things that she didn't understand, and so he retells and checks again. And once she has been able to teach back the information, they together develop a care plan. Interestingly, they decide to remove 2 medicines that Maria was taking, but they've added a new antidepressant. And she's also going to talk to a dietitian, have an appointment to talk about how to adapt those Puerto Rican specialties that her family loves to be more heart healthy for her. And she's going to follow up with a cardiologist because she's been having a few worrisome symptoms. So the doctor leaves and in comes the nurse. And the nurse asks, what questions does Maria still have? And he asks her to demonstrate how she's going to take her new medicine. And he takes out a handout and starts highlighting and circling the key points about her new medicines and her treatment plan. And he gives her a picture of a medication schedule, you know, all the medicines at what time of day she's going to take each one and how much. And she can put it up on her refrigerator to remind her. But he also gives her a pill box to help her organize the medicines and make sure she takes them on schedule. So before she leaves, an assistant makes an appointment with her to return in 3 months, makes the appointment with the cardiologist's office at a time that's convenient for her and her husband, who's going to drive her, and arranges for an interpreter to be present because the husband's English is not proficient and he's going to attend the appointment. After Maria leaves, the assistant sends all the referral information directly to the cardiologist's office so that Maria is not responsible for relaying any information. And the following week, the patient care team follows up with her and they ask her about her medicines. Was she able to get the new medicines, how she was taking them, and asks about the appointment with the cardiologist. They also learn that the community exercise program that they had suggested she check out didn't meet at a convenient time, and so they give her a different suggestion. So in my book, Maria is really lucky. She's receiving health literate care. Makes it easy for her to understand health information and get the care she needs. But we're all not so lucky. So let's think about this quote from Dr. Regina Benjamin, who is a former Surgeon General. She said, if patients' understanding is incorrect or incomplete, we didn't find the right way to reach them. Being health literate is just as important for clinicians as it is for patients. And so this is our first step in kind of reorienting how we think about health literacy is not those patients who don't understand, but as what do we need to do to help make it easier for patients to understand and navigate the health system. And I like to portray this as a health literacy equation, recognizing that the patient, the person, brings their own skills and abilities, but that we have an ability to, another factor in whether or not somebody is going to understand information and be able to take action depends on how difficult that message is, how complex the tasks we're setting them. And if we can reduce the complexity, make it easier, then that is going to increase their abilities to understand and act on health information. And that's why I'm really delighted that we now have new definitions of health literacy. These definitions come out of the Healthy People 2030 initiative. And for those of you who aren't familiar, Healthy People is a national program of health promotion that sets every decade a set of health goals for the nation. And so we had just adopted our next decade's objectives. And with it, we came up with 2 new definitions. So we still recognize that there is personal health literacy. That is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. But we also have on a parallel track organizational health literacy, which is the degree to which organizations equitably enable individuals to do those things. So the focus of this presentation is going to be on organizational health literacy. I'm now going to pause there to see if we have any comments, questions, thoughts about what we're setting up here. And so I'm trying to look over the chat. In the previous research was the question about if the person read any of the information given to them. Raul, do you want to unmute and help me understand what it is that you're asking about? Sometimes it's a little difficult to find that unmute button.
Oh, I'm sorry.
There you go.
Thank you, Cindy. I'm sorry, I was having trouble clicking the unmute. Basically, when we give information to patients, I always wonder how much of the information they're reading. It's not only that we're giving the correct information at their level, at their school reading level, but also if they are reading the information. That's what I was wondering in that research.
Right. So, there is what we call the parking lot test, which I know organizations that have basically gone out to see how many of the handouts that they've just given patients end up in the waste paper basket on the ground, even before they get to their car or their transportation or the like. That we cannot assume that patients read anything we give them, and that's why in that example with Maria, that somebody actually went over the handout with her and marked it up to personalize it so that she would see what it is important that she needs to pay attention to. That can increase a person's investment in the document and seeing the relevance of it to them. But we have to make sure that, to your first point, that these are created in a way that it doesn't look like a wall of words and daunting and intimidating, and that it is in a language that they understand, whether that's English or another language, and that it's at, as you said, a level they can understand. And I'll be getting into some more of those points in a little bit. Any other thoughts or comments before I move on? Okay, we'll be having these little pauses throughout the presentation. Thank you, Raul. Really appreciate it. So I'm switching now. I'm going to talk about system change. So we're going to try and bring it up a level, because at the beginning of the field of health literacy, if you were following along, the research talked a lot about people with limited literacy or limited health literacy. And that's, that was very important to raise awareness. But it was a little blaming the victim in terms of just focusing on what was the matter with them. And So then we had a shift where we kind of looked more towards, well, you know, what can clinicians do to improve health literacy, improve their skills and their ability to communicate. And that's very important piece of the puzzle. But I like to say that even the most skilled, well-intentioned clinician can't single-handedly overcome health literacy barriers. And so we need to look at the system level of what can change on that level in order to make sure that we're really meeting the needs of all of our patients. I want to share with you a picture that I think may be familiar to a lot of you. So it could be an old friend, the chronic care model. And the chronic care model was one of the early models that recognized the health system, that how you design the delivery system makes a difference, that the clinical information systems, the self-support management, and that the health system also resides in the context of a community. And the model poses that if you get all those pieces right in the system, you're going to be able to have prepared, proactive practice teams, and they're going to have these great interactions with these informed, activated patients to create improved outcomes. And some colleagues of mine and I put a health literacy lens on this. We said, we think there's a missing step here. And so we created the health literate care model, which interposes this purple circle in the middle between the system and those clinical interactions. And that level is health literacy strategies, because you're not going to get an informed, proactive patient unless you've improved your written materials, improved your spoken materials, linked to supportive systems, that there are all these pieces that a system needs to address to actually achieve those productive interactions. And so a lot of things that I'm talking about are trying to get at that middle layer of the health literate model. I had the privilege to study a number of organizations who had done health literacy improvement work. I interviewed organizations from around the country, and I noticed a pattern that which they approached their health literacy work. A lot of them began with literacy, with being concerned about the 20% of adults who don't functionally read or have difficulty, and they really focused on written materials, from the patient handouts to the wayfinding signs in their facilities. And then often they graduated to spoken communication and started trying to implement strategies around improving, making sure that patients understood what was being said in the clinical encounter and instructions and medication safety. And then we saw recently a bit of a watershed change that I've observed with the advent of value-based payment, which is moving away from the old fee-for-service payment to providing incentives for patient outcomes, that we've had an uptake in the interest at the organizational level in health literacy, that value-based payment provides some flexibility to invest in systems that are outside of billable services that can support patients, and a financial incentive, that a recognition that you need the patient engagement if you're going to get good patient outcomes. And so lots of organizations started really diving into patient engagement and how can we increase our patient engagement, and realizing that health literacy had to be a big part of that. And so this has been sort of a path towards becoming a health literate organization and delivering health literate care. And so for those of you who are perhaps starting along this path to realize that it is a journey, and that there will be steps and missteps along the way, but that there is a progression. So I'm going to go on to the next section, which is Adopt Health Literacy Universal Precautions. And I happened to stumble upon a presentation online yesterday made by Karen Brown on health literacy. And at the end of that presentation, she was asked, what's the key takeaway for our audience? And she said that we should adopt health literacy universal precautions. So health literacy universal precautions is structuring the delivery of care as if everyone may have limited health literacy. And it's just the same concept as blood safety universal precautions. You cannot tell by looking whose blood is infected. You cannot tell by looking who has limited health literacy or who is understanding you at that moment. We can have higher health literacy skills and that doesn't necessarily translate to understanding. And just to give a personal example, I've actually written a number of kind of personal narratives about, just being an advocate in the healthcare system for my family. And, one time my mother had a hip replacement surgery and she ended up with strokes. And the day after, the surgeon was talking to me. Meanwhile, I had been up most of the night between having her transferred to a different hospital and trying to sleep on the floor of the room where there was no accommodation and the usual hospital routine. So I am both exhausted and scared. And the surgeon starts talking to me about, it's probably a fat embolized shower, but we really expect to see an insult to the lungs if that was the case. And I'm just like, my head is swimming. And I'm thinking, and in fact, I even said, believe it or not, what do you mean insult to the lungs? You say, hey, lungs, you're ugly. Well, he retorted, and I had asked him, I said, could you please use language that I could understand? And he was very insulted. In a different sense, in the sense that I think about it. He said, insult is a perfectly good English word, but it wasn't meaning to me what he meant it. He meant an injury or damage. And so it's why I say that health literacy is a state, not a trait. All of us can experience limited health literacy. And the good news is that everyone benefits from clear communication. I have yet to encounter anybody requesting, could you please make that, more complicated or use fancier words? Doesn't happen. So, it's been over a decade since AHRQ first published the Health Literacy Universal Precautions Toolkit in response to feeling that the field was kind of getting it, realized that there was a problem, and people were asking, so what do I do about it? And this toolkit, it was developed for primary care, but has been used throughout health systems, including long-term care. It covers a variety of health literacy topics, Oh, and by the way, there is a companion guide around how to implement this for practice facilitators or others who facilitate implementation of innovations and improvement. And we tried to practice what we preached. We developed these, short 3 or 4 page tools, each one with a set of action steps and suggestions for tracking your progress. And so that people can, just dive into one tool, work on improving that, spreading that throughout their organization, and scaling up from there. So I'm gonna pause there and ask about whether or not people, are, and there's some people whose names I recognize, so I know, but what is your experience with health literacy universal precautions? It's, oh, and I see a question from Andrew Pleasant. Oh, but it's private, sorry. Is this something that you've heard about and been intrigued about, or does this kind of sound like jargon itself? Has anybody tried to implement a health literacy universal precautions? And I'm very patient, so I'll wait for shy people.
Hey, Cindy, this is Andrew.
Hey, Andrew.
I didn't mean to make that question private.
I realized that after I looked at the question, and then I saw the private. So why don't you ask your question?
So there are 3 areas that health literacy, well, there's probably more than 3, but I want to point out 3.
Andrew, wait, Andrew, pause.
Yes.
Introduce yourself.
Oh,
Oh.
I'm a tall white guy.
Glasses, I know, come on.
With glasses, who spent too many years in college. Really. So look, there's prevention, right? Which is how to keep people healthy as long as we can keep them healthy, and as long as they can keep themselves healthy. Prevention, right? But then something happens and you need medical care, and then because most of the healthcare system doesn't focus on prevention at all. They just wait for people to get sick and then make money off of it. So that's the care process, which most of health literacy has always focused on. But then there's the third, which most of health literacy hasn't even addressed, which is end of life, and how to help people move through that process, which we all know is going to happen, and help their families move through that process. So I wanted to hear your thoughts on how health literacy is different, or if it's not, in those 3 domains: prevention, care, and end of life.
Yeah, and I not had, on the fly.
I know, I asked out of the blue.
Yes, no, but I love it. I don't see health literacy as necessarily changing. But obviously the context in which you're applying health literacy strategy changes. And for me, this is a bit of a trick question, because I am also heavy into shared decision-making, which I'm going to go, way out there. I actually think that's a misnomer, because it's the patient and family that gets to make decisions, and the health professionals are the consultants and providing expertise, but it's really our decisions. And by the way, I didn't include in my disclaimer, I am not a clinician, surprise. There is also a huge palliative care movement, which I think health literacy has a strong role in, because it's all about trying to meet the whole needs of the individual patient and the family in reaching their goals. And so eliciting a patient's goals, values is part of that process, but they can't make the decisions if they're not understanding really all the ups and downsides of the different options. So for me, it's part of that whole process of making sure that there is clear communication so that patients can act upon information. Andrew, you want any follow-up? Or I also see Lynn has come on the screen. Wonder if she has a question.
We'll move along because you and I could have this conversation for an hour.
Good. All right. Well, perhaps we shall. Lynn, something on your mind?
Yes. So I texted my question. I think the group that's within an organization that is typically the most resistant to plain language is the legal group. And I was wondering if you have suggestions for working with them to, or making more compelling arguments for changing things, such as clinical trials consent forms, for example. Right, and my second question is also from a research perspective. We talk about phase 1, 2, 3 of clinical trials, and we're still using those Roman numerals, the 1 and then the 2. So, and a lot of people don't get that, 4 is IV. And that's the government standard. Is there any possibility of that going to regular numbers?
Right. So if you're part of an NIH multi-site clinical trials, they're trying to get everybody to do everything the same, and it's an uphill battle. But there are changes that you can make, and a few things that I'd like to mention. One is, of course, a few AHRQ tools that might be helpful. So we developed a AHRQ informed consent and authorization toolkit. And Karen, I apologize, I did not put these resources on the handout, but I can send them to you. And that is not clinical trials, because AHRQ mostly does minimal risk research, but it is, it provides some examples of consent forms, and we worked with HHS's Office of Human Research Protection. And people sometimes don't realize what a simple form can look like, and what, oh my God, yeah, I could just say, you don't have to be in this study. I don't have to say participation is voluntary and so even just providing examples of language. We also have a training tool which is geared towards informed consent around treatment. And that is 2 trainings. One is for hospital leadership, and one is for healthcare professionals. If you're affiliated with the Joint Commission, you can take it for free on their learning management system. And it is really, the healthcare professional one is really the integration of the shared decision-making and the health literacy strategies together. So that's another tool. The other thing is, there is a gentleman who sort of specializes in informed consent in law, His name is Chris Trudeau. He's a lawyer by profession, and he is with Arkansas Center for Health Literacy. You're nodding at that you know him. And there is some precedent that says, you know, legal department, you're not actually providing protection against lawsuits because the courts find that if the patients can't understand it, it's not informed consent. But I think the best strategy is the co-option strategy, which is, you know, try and invite them to be part of your health literacy improvement efforts. And as they, and you know, say you understand their concerns, but this document here is actually supposed to help the patient understand what they're agreeing to. The other big thing about the informed consent documents is that they are just the documentation of a conversation. So in that informed consent and authorization toolkit I mentioned, we also talk about using the teach back process in the informed consent discussion, that, you know, you need to roll those health literacy strategies, not just in, okay, this is the thing that they sign, but in that conversation that they're having, which is the most likely way for them to really understand you know, what they're agreeing to or disagreeing with. Okay, we're having some great chat discussion. So I'm going to ask if any of you who chatted want to unmute. And I think I saw something from Amy. Where did that one go? That has she used?
I would like
Yes,
to say
Amy
something.
Mirabel. Sorry, yes, Charlene, go ahead.
This winter, I fell on my knees on the ice, and I went to a very respected orthopedic surgeon who said, took x-rays and said, there's no broken bones, but you just need a knee replacement. And I just didn't feel that that was accurate, even though I'm not a physician. And so I've been limping with a cane for 7 months and in pain. And my family was implying that I just don't want to get that surgery. But my intuition was telling me that it was not necessary. And just a week ago, I was referred to a family physician in a sports medicine clinic. And he said, I have a different approach. And so he just did kind of the reverse of what the orthopedic surgeon did. And my knee problems were gone. I walked out of his office after this minimal procedure. I walked without pain, and I walked without limping. And I just felt like my gut feeling or my intuition was guiding me to try to stumble and find the person who had the right answer for me, not and just trusting myself in that. And I'm very happy I'm now pain-free and not limping after 7 months.
Well, that I'm so happy for you, and I think that your story dramatizes an endemic problem, which is patients by definition have less information, less expertise than the professionals, but they may not share the same goals. And it's very hard for a patient to assess the advice that they're being given. And I had a very similar situation. My husband fell and broke his collarbone. The first guy said, well, maybe you need surgery and we'll just tentatively schedule for next week and that sort of thing. And we got a second opinion. But, most people don't have the capacity to really, get multiple opinions, and the fact is, I didn't know whether he needed surgery or not. Maybe he didn't. He may still. There's a, they say that the second surgeon even said there's a 10% chance he'll still need surgery. But what I think your story also tells was that clinician didn't, ask what was important to you, didn't lay out all of the possibilities and, suggest that there might be some alternatives. And that's just, I think, endemic of our ultra specialized system. An orthopedist is a surgeon and that's what they do. But I'm gonna bring us back. Let me just see about checking in with Amy Mirabella, because you mentioned that you've created a health literacy task force, and I was wondering if you want to comment on your experience of using the Health Literacy Universal Precautions Toolkit. I think that would be really interesting.
Sure, can you hear me?
Faintly, but yes.
Okay, so I am an oncology research nurse and work in a phase 1 clinical trial institute. And we noticed, the nurses noticed, that patients were having a hard time understanding directions. We were admitting patients to the hospital because they hadn't taken their medications correctly. So a group of nurses got together and said, hey, what can we do about this? So we started to dive a little deeper, came across the toolkit, and now we've created this health literacy task force that's being supported by leadership within our institute. We're at the very early stages where now we are educating all the different departments within our clinic, including the people who work the front desk, the finance people. Every department is getting that education. We'll be working with people individually one-on-one to go through the teach back process, and then, mentoring them when they have conversations with patients and that sort of thing. We're looking at our bulletin boards. The toolkit has been a blessing because it's all right there. We just have been following it step by step, and we're amazed at the support and how much the clinic wants to know more. And now the hospital that we're associated with has heard, and they want to start looking at how they can potentially use it as well.
Wow, you just made my week. I love to hear that. And where are you located, Amy?
In Scottsdale, Arizona.
Oh, okay. Well, I was thinking that if you were in the Finger Lakes region, you could serve as a resource for colleagues who are on this webinar. But, as Lynn is typing in, we love hearing these stories and sharing experiences. So I hope other people, as I continue, will chime in. I'm seeing if I can type at the same time as I can talk. Probably not. That sharing your experiences on the ground, it's just invaluable. So I'm going to go back, speaking of sharing, to sharing my screen. And Karen, did you want to get in here?
Nope, I was just going to let you know that I do have the list of people that are here, as well as their contact information, and I will keep track of the questions as they're going in between.
Super. And I've even figured out how to share my screen on the correct screen. So I'm gonna dig now a little bit into some of the really important strategies for improving written and spoken communication. And a lot, there's a lot of guidance out there. This is not going to come as a surprise to people that we need to pay attention to the language, make sure, we get across early and often what the purpose is of what we're trying to communicate, not use jargon, use a tone of voice that's like everyday language, that it also matters what materials look like and how they're organized. Not rocket science here, but nevertheless, many of the materials that people hand out are not friendly. Let's put it that way. So what do you do if you're an organization that needs to and wants to share written materials? I'm suggesting that you establish a process for evaluating what you have. And it could be using a formal assessment tool, such as the PMAT, which is the Patient Education Materials Assessment Tool, another AHRQ tool, that will assess both the understandability and the actionability of materials. But the gold standard is to have materials reviewed by your consumers, your patients, and we'll get back to that in a minute. Once you've identified materials that aren't good, you need to do something about it. So you either have to find ones that are better out in the world, or you have to create your own. And I have included on the handout a lot of guides, resources that you can use to develop your own materials. But these days, increasingly we want to think about alternatives to print as well. So one of my favorite guides, just to shout out, is this one that the Centers for Medicare and Medicaid Services have. It's called the Toolkit for Making Written Material Clear and Effective. And at first it seems like, oh my God, this is this huge, 11 chapters, and each chapter has multiple parts, and no thank you, it's just way too much. But it really practices what it preaches. It really chunks out the information and lets you just find the part that you're interested in learning about at that time and dive into that topic. So for example, I mentioned, the gold standard is checking in with readers, and it gives you specific strategies and takes you through them of how you might get feedback from people who would read your materials. So just recommending that one in particular, but there are many out there. So moving to spoken communication. Again, what you see on the screen slide here, we all know these things. We all know we should use plain non-medical language, slow down, limit the content, and repeat the key points. All of these things that, we should be doing, but very often we don't use them. And part of that is that it's not how patient visits are structured. So if you think about the system level, what can you do about that? Well, there's the training that helping people to develop the communication skills, but it's also about, how much time are we allotting for that visit? And team care. So in the example that I gave of Maria, there are many different people on the team who can help reinforce messages, find out information, and do that critical follow-up. So, thinking about it at the system level, because very often we communicate and we think we're understood. We just assume it. And unfortunately, all too often, it's just an illusion. Now, how do you really know when patients are understanding? You know, well, they nod. Yeah, well, that's not a good sign. You say, well, do you understand? And they say, yes. Just that's an automatic response. You know, asking questions is a good sign, but still doesn't mean that they're understanding and they have responses. And you can't just assume that, you know, if they have good health outcomes, they're understanding everything. So I want to pause here to ask people, you know, have you ever had an aha moment where, you know, you realized that somebody wasn't getting what you were saying and you thought they had understood? And while I say write it in the chat on the slide, please unmute yourself if you care to share with us a story here. So I'm going to pause.
I'd like to make a quick comment. I'm a psychotherapist and I was doing couple counseling and I was using the word empathy and the couple was nodding and smiling. And so then I said, what is your understanding of what that word empathy means of each of them? And I realized from what they said that they actually had no idea what that word meant. And it was so pivotal to our communication. So if I hadn't asked them what was their definition of it, we would have had a very unproductive session. And I appreciated them being honest with me and that me remembering to ask them what they believed it meant. Thank you.
Thanks, Shelly. I see a great chat from Nikesha, and I'm going to ask you to speak up in a little bit because you're talking about sort of health literacy initiative, and I think we should talk about that. But I want to wait until we talk about the health literate organization, if you don't mind. And Amy Knapp had asked about accessibility. And, you know, there are, and you raised the issue of color blindness. There are a lot of, you know, considerations in the federal government. We have a whole standard around accessibility and disabilities. If you're talking about online resources, one resource which I do have on the handout that you might want to consult is called Health Literacy Online. And they have some suggestions for making sure that materials that you post online are accessible. So, so I'm now going to bring up one of the health literacy tried and true poster child. And actually, let me see if I'll be able to see this. How about if you raise your virtual hands if you're familiar with the Teach Back method? And I'm just going to scan the participant list here to see. Oh, I got a thumbs up from Karen, but I was actually looking in the participant chat. Amy, Mike, great. Michelle, Ellen, good. So it's still a minority. All right, so I'm going to spend a little time on this because it is super important. Because to me, this is really the answer of how do you know whether people are understanding you. You can't know unless you've heard it from them themselves. And so this is a way of, it's sometimes called check back also, that you chunk out a piece of information that you want to teach somebody. And then you ask them to teach it back in their own words. Now, this isn't a test. It's not about memorization. They can look at materials you've given them. But what you want to watch out is you don't want them to actually parrot exactly what you said, because I can play the tape recorder back. It does not indicate that I've understood anything. Just like, you know, if you're at the dinner table and somebody says something and you weren't really paying attention and they say, you know, you're not listening to me, and you can spit it back, but it doesn't mean that you've understood it. And then one of the important pieces about teach back is if the person wasn't able to explain correctly what it was that you were talking about, you have to teach them in a different way, that you can't just repeat exactly the same thing and expect them to understand the second time. And that this is a process that recurs until they are able to teach it back. So this is not necessarily a easy, I mean, it's a straightforward concept to think about, but implementing it can be really difficult. People feel awkward. And so we've developed some, you know, phrases or, you know, teach back openers of how you try and make it clear to them that you're not, you know, condescending to them, but you're trying to engage them. So something like, you know, well, just to make sure I've explained things well, can you tell me in your own words, da, 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 da. Or, you know, acknowledging, you know, we went over a lot of information today. Can you tell me, or normalize it? You know, I've noticed many people have trouble remembering how to take their medicine. Can you show me how you're going to take it? I once did a in-service at Howard Hospital, and I asked people if they use TeachBack, and I was surprised that this was, you know, at least a decade ago. A lot of people raised their hands. And what I learned as a result of, you know, talking about it and teaching them and getting a demonstration, somebody to do a mock TeachBack with me, is a lot of people think that, say, asking, do you understand, is TeachBack. And that is, you know, sort of classically not what you want to do, because people will just nod and say yes, no questions, and you don't have an idea of whether they understood or not. Just a shout out to a resource that AHRQ did not create. This is a free online resource called Always Use TeachBack, and it provides training for the individual who wants to use TeachBack. And by the way, TeachBack is very useful in your everyday life and not just for clinical encounters. It also includes implementation guidance, like around coaching people to do TeachBack or assessments, things like that, to introduce it into a setting. One of the things I hear a lot from clinicians is, I don't have time to do TeachBack. And they're right. They don't have time, because if you think about TeachBack as an add-on at the end of the visit, they're already trying to cram too much into that visit. Some of the ways that you can help them see that it's in their interest to try and integrate TeachBack into the conversation is that, you know, they may get fewer phone calls asking questions. They may have fewer times where lab work hasn't been done that you had asked them to do, or that they're adhering to their medicine regimens better. That you have more engagement and better trusting relationships and higher patient satisfaction. So a sort of leaf out of Ben Franklin's book, an ounce of prevention is worth a pound of cure. And just to tell you this little story of, you know, what what it can take to try and get people to do teach back, and what the impact can be. This is taken from a case study that we develop at AHRQ of a community health center in Massachusetts who was using the Health Literacy Universal Precautions Toolkit. And they did an assessment. There's an assessment tool in the toolkit, and what emerged from that assessment for them was that spoken communication was really the priority. And so they integrated it into their policies and into their measurement. So, you know, they made sure that when they hired new people, the orientation training included health literacy, as well as annual in-service trainings. And they, you know, focused on trying to remind people to do teach back. They used newsletters. They had stickers to put on your computer. They, you know, heralded Tuesdays, or, you know, teach back Tuesdays. Let's everybody remember to use teach back. And what they found after a year was a majority of people were using teach back, and over 3/4 of them said it changed how they communicated. And after the second year, they had 91% of clinicians reporting they were using teach back, and 88% reported it increased patients' participation in their care. Excuse me, this is my voice is starting to go. So another pause. Does anybody want to share any stories? You know, we had a number of people who said that they were familiar with teach back, maybe used teach back. Do you have any stories that you want to share about how it worked or didn't work in your setting? I see great chatting going on, but I'm hoping somebody will also speak up. Oh, Mike, yes, ask a question.
Hi, Cindy. Thanks very much. The question I've got is, when I do awareness raising about the subject of health literacy, particularly with general practitioners and clinicians, and we talk about teach back, I share all the lovely information about you'll have fewer return visits, increased adherence, but I've struggled to find evidence, peer-reviewed evidence, that shows that teach back doesn't take longer and isn't a bit of a pain for the doctors. It's one of the bits I find hardest to explain.
Yeah. So a couple of things. One is, and you're right, there is evidence about teach back's efficacy. There have been studies that show, you know, improved blood sugar control and systematic reviews. The studies that I've seen, I think one showed it didn't take longer. One showed it took 3 minutes longer. And what I've heard from the field is at the beginning, it takes longer, that before they get used to it. And so one of the implementation strategies that we suggest is, you know, try it out on your, you know, last patient of the day or your last patient before lunch, so that it doesn't throw your whole schedule off if you're finding that it's taking you longer. But that what happens is, as they get used to integrating it into the visit, that it just becomes part of how the conversation and how they interact with the patient, and that there are more that becomes less, you know, I'm telling you what to do, and then I'm checking to see if you understand, to an interactive conversation, which actually can be more productive. So there's a learning curve. But that's the strategy that I've heard being successful in terms of helping people get comfortable with it. Does that make sense to you, Mike?
Yeah, it does. Thank you very much.
Great. And you don't need to
Hey,
ask questions.
can I add one thing to that? This is Andrew.
Yes.
So I agree with everything you said, but and I'm not the biggest teach back fan in the world, but the idea is that if you use the process, that in the long run people will be healthier, and thus that time burden will drop because people don't need to seek care because they're healthier.
So that is definitely the long view, and that's where kind of value-based payment pays off. But if you're still in the fee-for-service system, you have people in health systems saying, why wouldn't I want patients coming in for more care?
Well, see, once again, we could talk about that for an hour.
Yes. Well, we know that, but what Mike was asking about is a very real phenomenon of,
Totally.
This is the world I work with, and I have so many minutes to spend with a patient. You're asking me to do one more thing on this huge long list, and we're just not, we just don't have time for this. And so I agree with you, seeing it and helping motivate them by saying your patient's health will benefit is a big motivator. As well as, some of the short-term workload benefits, as well as a long-term benefit. But they also have to figure out how to do it in the here and now. So I agree also with everything you're saying. I just think that it can be, a tough sell. Another strategy, Mike, is finding some people who have done it successfully and get them to be the ones to tout how good it is. So, a lot of different implementation strategies. All right, I'm doing it.
Cindy.
Yes.
Just the one thing too, to just jump on with Mike, and that is, I think it's the challenge is trying to not only get somebody to jump on board, like you're saying, as far as someone who's doing it successfully, but then asking to track those outcomes, because when we talk to people who want that evidence-based or want to be proved because they only have so many minutes, I think it's really important to try to somehow in the long run have those people who are those teach back champions somehow do a metric to be able to show, because especially when you're talking about the outcome-based information, if we can show the differences. Just a thought.
And if you're in a teaching environment, I know that people have done this where, like, having residents do it as a project and tracking every day and things like that. So there are a lot of, very often when we think about tracking, thumbs up from Mike, when we think of tracking, we think it's some elaborate, got to get into the EHR and collect it on every patient, that there are a lot of quick and dirty ways that, I don't mean dirty, but of just, capturing for a small sample and getting credibility amongst people to build that.
Yeah. Can I come back in again? Just
Sure.
Yeah, I completely agree with your tactics for trying to convince people who perhaps need convincing. But I think, in my experience, whichever country we're trying to fly the flag of health literacy for, to me, it's a bit of the holy. I think teach back is just the best thing, but it's kind of our holy grail. We need some evidence. I think we still need scientific peer review, because we're talking to people who've grown up expecting science and peer reviewed this, that. And so I think it's beholden on all of us who work in this field to demonstrate it to quite a rigorous level. And if we could do that, then I think that would be a great leap forward.
And Mike, I'm going to see if I can dig up a couple of citations on teach back and time.
Thank you.
Send them to Karen to share with you.
Thank you.
Sure. All right, so I'm going to move along to a often neglected aspect of health literacy. So, you know, to me, language barriers are kind of the duh of health literacy. Like, if you don't speak the same language, how do you expect to communicate effectively? And yet, very often it's kind of like, oh, that's not health literacy, that's something else over there. So I want to spend a little bit about time about the real, you know, safety concern for patients with limited English proficiency, and what we need to do to address those. So first, there's assessing language preference. And this is, again, at a system level, you know, collect the data about both what language people prefer to have their healthcare encounter in, as well as what their proficiency with English is and what they need in terms of language assistance. Next, only using acceptable language assistance. And by that, I mean not using ad hoc interpreters such as minor children, big no-no, or, you know, a nurse who hasn't been trained as an interpreter even. That we know that there are greater errors for people who are interpreting who have not been trained. And that can present safety problems which have been documented. One of the problems with health literacy and cultural competence is the assumptions that we all make. And so in health literacy, we've talked about assumptions that, you know, you read at a certain level, you can do things with numbers, you understand my jargon, or even medical concepts, or how your body functions. I'm assuming all that. And the same thing is true in cultural and linguistic competence. Very often we're assuming that, you know, if people speak some English, they're going to understand us. We assume that they share our biomedical model of health and allopathic medicine, health beliefs, religious beliefs, health practices, that they eat the same kinds of food, that they use the same kinds of home remedies, and those can often be way off base. So I want to give you an example. It's an old one from the literature, but I think it's really poignant because it's actually not about people with limited English proficiency. It's about African-American women who lived in New Orleans. And the study showed that they believed that there were two kinds of blood pressure related illnesses. One they called high blood, and they thought that high blood could be treated with blood pressure medication. But there was another illness called hypertension, and that was not responsive to medicine. So if you prescribed medicine for somebody who thought she had hypertension, she wasn't going to take it. So this is an example of sort of health beliefs that if you are not communicating clearly, if you are not understanding their cultural context, you're going to miss the boat. And surprise, she's not going to get better when you prescribe medicine. She's not going to take it. So thinking about the system level changes to provide culturally and linguistically appropriate services, we of course need training in health literacy and cultural and linguistic competence. We need to think about the team more broadly, think about including interpreters in that team, including community health workers. And we need to think about our self-managed support in a way that elicits those barriers, so that we can confront them and talk about together about how to resolve them. So I'm going to provide a example of a guideline, in this case, a COVID-19 guideline, and actually a class insensitivity, not culture or language per se, but something that's very relevant. So this is a progression, a learning experience that we had during COVID-19, where the CDC first put on their website the guidance that if somebody was sick, provide them a separate bathroom and bedroom, isolate them. And when I read that, I was like, great. How, what are people who are living in overcrowded conditions who, have no idea, what a separate bathroom for a person would look like, because they have one bathroom for their, family of 7. So then we saw that the CDC kind of realized that maybe this sounded a little insensitive, and they started acknowledging the reality. So they realized to say, okay, we'll try and do this if possible. And if you can't, maybe just try and separate them as much as you can. So at least that they didn't lose a good chunk of their audience because they said, you're not talking about my life. And then they went one step further and they got to providing alternatives. What can you do if, you have to share a bedroom with someone? And so, they said, okay, well, let's see if we can keep the air flowing, and came up with a whole bunch of suggestions of what people might be able to do. So this is about being relatable. Will readers be able to see themselves and their culture reflected? And again, sort of to the question I think Raul posed earlier about will they read it? If they start looking at something and it looks like, clearly this isn't about me and my life, they're not. We have to also be careful about stereotypes, that we're being respectful, that we're acknowledging that people are different and complex. We want to make sure that people see themselves, even in a literal way. Are the images that you're using materials reflecting diversity? And very often, we start with an English language thing and then we translate it. But maybe we can create those materials at the same time to take into account different cultural differences and make it fit better with that population. And back to that golden rule of testing with your readers and making sure that those readers are as diverse as your target audience. So I'm going to do another pause here. I'm going to stop sharing for a second just in case people feel braver about unmuting or and I'm also looking at some of the comments. So any comments on the cultural and language dimensions of this? Yes, Lynn.
I think one of the big challenge we have is the challenge of translation versus adaptation. And when we use the translators, I think part of what they do is they try to translate. I mean, there's, they have their guidelines for what is good translation, but it becomes nonsense in in that language that it's being translated to oftentimes, simply because, I mean, if it's just very simple stuff like do this, this, and this, then it's okay. But if there's a little bit more complexity, I mean, so a lot of times it has to be adapted, particularly if we're doing focus groups, personal interviews, the words, the script just doesn't translate well.
Yeah, no, that's an excellent point. So you've raised actually several excellent points. One is using a quality translation process. And, you know, obviously not machine translation, not just translate back, translate, you're done. Very often what we've used is having groups from different cultural groups that speak the same language independently translate and then confer to reconcile their translations, and then bringing it to the audience. You know, it is a humbling thing to try and get the cultural dimensions as well as the language dimensions accurate. So I don't want to minimize the task. In you know, it is very difficult, but you know, critical, especially when we're talking about public health issues at a time where we need to be communicating really clearly to our target groups. Anyone else?
Hi, Cindy. My name is
Amanda.
Amanda. Hi, I'm Amanda K. She, her pronouns. I work for public health out in Seattle, King County, Seattle. And I am the program manager for the COVID language access team. And we have been working for the past year to translate these documents for COVID-related issues we've done upwards of 45 different languages. And so I fully can appreciate and understand all of the trouble that folks are having. And one of the things that we found to be really successful is that we hired on as contractors members of the community to help us do these translations. So these are folks who live either in King County or Washington State. They're local, they're in the community, they understand the community. And so they are doing translation, but they're not just doing translation. We also actually pair people together. So we have a translator and we also have a community reviewer. And so both of those folks work together in collaboration to create the best translation of the material that we're putting out. And we give them a lot of leeway to transcreate the document into a way that makes sense for their community. So a lot of the times, you know, words and language in English don't translate well into Chinese, for instance. And so we give the latitude to our translators to rephrase, reframe within reason, right, the information that we're giving. And we found that that's been very successful for us in communicating out in Seattle.
Well, Amanda, I have a request for you because that really sounds like a model practice. So first request is, you know, write it up, share that information, you know, how that works, because, you know, there's another process called bootleg translation, which is, you know, getting the whole community together, but it's a huge process to translate, you know, potentially one thing or one set of things. And what you have, I think, is a very pragmatic, streamlined approach of bringing in the community with the translation expertise. And I think people would really benefit from hearing about that more broadly. And then the other thing is just, I hope you're, you know, letting the world know at large that you have these materials available in so many languages.
Sure, I'll put our COVID information in there, and then I'd be more than happy to put my email in there in case anyone had any additional questions. And thank you so much for this. This has been so informative. I really appreciate your time.
Oh, well, thank you. This is so rewarding when I get this kind of interaction and you telling me things I benefit at least as much. So looking at the time, I'm going to move us along, talking a little bit about the Health Literate organization. Now, I gave you earlier a definition of the Health Literate organization that we just unveiled in 2020. This definition hails from a somewhat earlier period where we actually more or less coined the term. It started at the Institute of Medicine, which is now the National Academies of Medicine, where it was inspired actually by the national class standards, the national standards for culturally and linguistically appropriate services, which were issued by the Office of Minority Health, that has no regulatory authority, no payment muscle, just kind of answering the question, what do you do? What does it look like if you are delivering culturally and linguistically appropriate services? And I kind of felt like the health literacy field was at that point. What does an organization that is health literate look like? And we commissioned a paper that Dean Schillinger and Deborah Keller wrote. We had a whole workshop where people talked about the different attributes, and we basically honed in on a set of attributes that that was going to make it easier for people to navigate, understand, and use information, take care of their health. So you may have seen around these 10 attributes. The first 3 are kind of endemic to any quality improvement effort. You need the leadership out there saying this is a priority, promoting health literacy. You need to integrate it into your strategic planning, into your safety planning, into your evaluation measures, into your quality improvement. You need to prepare the workforce, hire the right people, train people. And then we get into a set of attributes that is more specific to health literacy, about including consumers, including those who have limited health literacy in your planning, in your material development. Making sure that you don't stigmatize people, that you can meet everyone at the level that they are operating at. We've discussed some of the interpersonal communication pieces, ensuring easy access, material design, and then also acknowledging that we can't do everything at once. And so we should really prioritize activities that could be high risk. So for example, transitions in care, you might say, or you might say, an INR clinic. I guess these days we have blood thinners that you don't need those, but similar kinds of situations of discharge planning where people are at risk, and we want to really make sure we're being clear. And then the final attribute is one that we have done terribly at, and therefore wanted to call out specifically, which is that people are entitled to know what they're going to have to pay for something before they decide to engage in a service or a procedure, so that we need to explain coverage and their out-of-pocket costs clearly. So I'm just going to tell you a little story of an organization that, at the time that this was relayed to me, was pursuing being health literate. I'm not implying that they're not now. I'm just saying I haven't necessarily kept up with them. And Nova Health is a nonprofit integrated system. At the time, they were the 5th largest medical group in the country. And they decided they wanted to become a more health literate organization. So they engaged in extensive assessment activities. They got patient and family and staff stories, and what their vision of a health literate experience was, and did some mapping. They analyzed their patient experience data from the HCAHPS. And then they engaged in strategic planning. They actually got coaches to talk about the remarkable experience and develop action plans with specific steps to take. And they managed to train 97% of their staff in clear communication. And oh, sorry, I went a little too quickly on that. Let me get back that. And they integrated health literacy into one of their big flagship initiatives, which was First Do No Harm. It was a big safety initiative. Well, let's infuse that with health literacy. You know, they got all over their education materials. They set their goal at not, you know, 5th grade or lower. And what they found was some real benefits. So, you know, their stroke center documented increased understanding of diagnoses, of both the importance of a treatment plan and the understanding of their treatment plans. In heart failure, their self-management knowledge scores went from 38% to 85%. And they had a general increase in satisfaction with how well doctors explain things in a way that was easy to understand, which is one of those HCAHP measures. So seeing some real concrete benefits. And what I'm trying to underscore here is the importance of hardwiring health literacy improvement. That if we treat health literacy as sort of a quality improvement project, then, you know, when the project is done, the attention often wanes. So, you know, let's think about what does this organization need overall? Let's do an assessment. Let's develop a plan and build the workforce and the structures within the system. So we can establish new policies, we can measure our progress, and last, we can shift the culture of the organization. Some people think, oh, you know, we've got to change culture right away because culture eats strategy for breakfast. That's a saying in the improvement world. And it's true, but it's often the last thing that comes along. That once you've got all these other pieces in place, you'll get the cultural shift as well. So what can you as individuals do? You know, raising awareness, forming a team, and this is where I want to get back to Amy's comment about her non-existent team. Developing an improvement plan and partnering with patients, because health literacy has got to be a way of doing all the work we do, not new work. It's how we do our other work. And just my general infomercial for AHRQ resources, we have a health literacy microsite where you can find a lot of tools. And I'm going to save parting thoughts and go back to the team. Amy, would you be willing to unmute and tell us a little bit about the task force that you tried to form, or we were asked to form, or you're part of, and let's brainstorm that as a group.
Sure, can you hear me?
Yes, thank you.
So we proposed with our task force having approximately 11 to 12 people. We have about 120 people that work in our clinic. So we specifically chose people from each department. We wanted every department within our clinic to be well represented. So the first part was really using the toolkit, to provide some education to those members of the task force, because some of them got asked to be part of the task force and they didn't really understand health literacy. And now they are the champions for educating within their department and trying to move things forward. So we chose a couple things to work on first. And one of them was staff education. So the staff education has been released this week, as a matter of fact. And so we'll have staff working through, with the AHRQ, the pre-test, the presentation, and the post-test. We changed the presentation up a little bit to add some specifics for our clinic so that the people who were doing the education could understand how it directly related to the patients that we work with every day. And then the task force has broken into different subcategories with different projects being worked on. And so we have 3 various projects working on right now. We're wrapping those up, and then we'll keep working through the toolkit. In fact, we're meeting tomorrow to decide what's going to be the next step. And then through the process, we continue to report to leadership about what we're doing. And I love the Teach Back champion. And so I just took notes on that because it'll be the next piece that we're going to be doing.
Great. Well, Amy, I'm really curious. So you had some people who were kind of voluntold, and you turned them into champions. I'm eager to hear how did you do that?
The first step was having a one-on-one discussion with the person and talking about the strengths that we saw, the leadership style that we saw in them, and then the importance of health literacy. And so that was sharing some of the statistics from the toolkit and how we have patients traveling from all over the world before COVID to be treated here. And what were some of the gaps that we were seeing? And everybody, including the finance department, had those aha moments like, oh, yeah, patients don't understand what I'm telling them. Well, so how can we use the health literacy piece and including the teach back to ensure, understanding? And then they were able to see, yeah, this may decrease phone calls to my department. This may decrease how many meetings I have to have with this specific patient. So we really made it applicable to the work that they were doing.
That's great. And now Zainab was asking, how do you advocate for funding for health literacy, like training initiatives? How did you get your leadership buy-in to fund that?
So we spent the past year doing a study, some of the nurses did, that was funded by the Daisy Foundation. And so it was a nurse-led study where we created specific patient education modules that were based on this universal approach to health literacy. We assessed our patients' health literacy, and then we used these modules with each patient. We had 68 patients that went through it. And the feedback that we received from the patients about the learning that occurred, the different things that happened, and about how interested, they were so happy that we were interested in them more than their cancer diagnosis. Our leaders just ran with it. So we proposed this task force, and they have been fully supportive. I would love to, write that story up, because that's gold, and that's how, everybody learns. I would also add, the value-based payment twist, which is, like you mentioned, the CAPS measures. So if you have any kind of funding that is based on CAPS scores, like for your Medicare patients, there's a question in there, how easy it was to understand. Did my provider spend enough time with me? Did they respect me, etc.? And so we've seen in a lot of health systems who are very interested in increasing their scores on those, being willing to invest in strategies to help improve that. So that's another hook that you can have there. Karen, I see you've come back on screen. Did you want to jump in or redirect us?
Nope, I was just showing my face.
Good. Good. All right.
Letting you know I was here if you needed me to help at all.
Thanks. So there was another question in the chat from Kim that said it's been very difficult to find any information on health literacy vocabulary. So I would like you to come off mute just so that I can check if I'm understanding what you're interested in learning about. So you're talking about sort of a glossary of easy to understand terms. Kim, if you're talking, you're not unmuted.
Sorry about that.
No worries.
When you have headphones and they get their microphone turned off.
Yeah.
We actually are working, and Ellen's on the phone call, and Jessica and a couple other people that we are working together. We are trying to put our own vocabulary list together on medical terms so we can use them in educational materials. But I was wondering if there's already something out there, because it's difficult when you start getting into the larger words and doing explanations and stuff of that.
Yep. So there are a couple of things, but I'm going to start off with, a plea to try and avoid terms. There are sometimes reasons to include medical terminology, like, somebody's going to say it to them and you want them to know what it means. And of course, always define a term when you're using it, but we want to do that as little as possible. So there are two resources that I can think of off the top of my head. One is the CDC has, trying to remember what it's called. It's not called a glossary anymore. There was a sort of rogue CDC glossary out there that was like a thesaurus for many years. And then they issued an official document, which isn't just a word for word substitution, but also shows you how you can rewrite a whole sentence so that it is going to be better understood and without the sort of triggering words. And I'm blanking on its full name, but that is something that I will also, if you go to the CDC Health Literacy site, you might be able to dig it up, but I will send to Karen. The other one is, I believe it is called a health literacy glossary, and it's put out by United Healthcare. So I believe it may err to the side of insurance terms, but also includes some healthcare terminology. Again, I will see if I can dig up a URL for that and send it along. Does anybody else have any suggestions for Kim?
I too am drawing a blank and was trying to look, but I'll put them in, I'll find the two that I was thinking of. For some reason,
So,
I'm drawing a blank.
Yeah, and Jacqueline, it is not the Clear Communication Index. The Clear Communication Index is a CDC product that's similar to the PMAT, lets you assess materials and has a user's guide on creating materials, but it's not this kind of glossary type of thing. There's a different document, and I will find it.
I don't know if I was just going to add that I'm with Kim's facility and specify that we are working in the subspecialty of hematology. So our patients are hearing certain words their whole life. So for us, that glossary avoidance of terms is not necessarily always manageable. Obviously, when that it's kind of a balance between avoiding words that are general and when we can work around those. But if it's something that you know, we're dealing with hemophilia or sickle cell disease, or you know, those words, like we can't just avoid those. We need to explain what anemia is or how the platelets work or that kind of thing. So it's just a balance. As I was just going to clarify of kind of where we're at.
Great. So I am conscious about the time, so I put on my parting thoughts slide. You know, I'm hoping you're taking away from this session that health literacy strategies can improve safety and quality of care, that there are many strategies and tools that can help you in improving patient understanding and informed action, and that we need change at the system level. So I'm going to challenge all of you, you know, and ask, well, what action are you going to take tomorrow to promote organizational health literacy? And now I am going to stop sharing and see if anybody's going to take my challenge. You know, one thing that you could do this week. And we've heard from a couple of people already, so thank you for those contributions that we've already had.
I am so excited. This is like a dream come true. I'm so excited that we were able to share this with all of you, and also to be able to record this, and we'll be able to share it on our websites and send it to everybody to share as well. Thank you so much for taking time to talk to us about such an important issue today. And I look forward to this list of people staying somewhat in a network and conversation to continue the work. So thank you so much for today.
Wonderful level of engagement. Thank you all. Your resources for each other. Great session.
Thank you, Cindy.